So we're going to try to dissect a little bit out, going through several of the main publications addressing this issue. And so we're going to try to figure out what the impact of heredity on pancreatic cancer is. And I think a good start is this nice review that Dr. Gloria Peterson from Mayo put together not long ago, where she really put together a good number of studies, some case control, some few cohort studies addressing the issue of the risk of pancreatic cancer in relatives of patients with pancreatic cancer compared to healthy controls. And interestingly enough, the approaches were different, the types of studies were different, the geography was different. There were some from Asia, some from Europe, some from the US, and consistently they had a very similar odds ratio of averaging about 3. Very, very consistent data across the board, with a relative risk of about, in cohort studies, of about 1.8. So some evidence here and pretty consistent evidence of some familial component here. Here, Klein and collaborators looked at a group of 838 kindreds from families that are part of the National Familial Pancreas Tumor Registry. So those are families who have at least 2 family members with pancreatic cancer. And as you can see here, they look and they compare, they assess standardized incidence ratio, basically comparing it with the expected incidence from the SEER data with those that they found in their own cohort. And what they see here is that having one first-degree relative gives you basically 4.5-fold increase in risk of pancreatic cancer. Having 2 first-degree relatives, that goes up to 6.4. And 3 or more relatives, that jumps up to 32 times more higher risk of developing pancreatic cancer. So there's truly an enrichment. The more family members, the higher the risk of the rest of the family members is. Down here, there's another study that's part of the Search Cooperative Study Group from the International Agency for Cancer Research. And what they did is they look at this population-based case control study from the area of Quebec in Canada. And from that, they determined that about close to 8% of patients with pancreatic cancer had a family history with pancreatic cancer versus 0.6% of control. So on average, there was about 13-fold difference between cases and controls, pretty much going on that same direction. And from all the studies, the pattern seems to point towards an autosomal dominant inheritance of a rare susceptibility, either gene or genes, though really the actual genes have been really very evasive so far. This is a GWAS study, the largest one that I'm aware of, on pancreatic cancer that was done on individuals with European descent. 7,600, close to 7,700 individuals with pancreatic cancer, and 14,000 controls. And here they identified at least 6 different loci in different areas, in different genomic regions, where they saw an association with pancreatic cancer. But refinement of these GWAS studies has not yielded yet any conclusive results in terms of a particular gene involved in these cases. So as usual, what happens when we really don't have a good handle on what genes are underlying the particular genetic syndromes, in this case we're talking about pancreatic cancer, we go back and we use our clinical criteria, which is always what came first. And traditionally, the criteria for familial pancreatic cancer is a kindred that contains at least a pair of first-degree relatives affected with pancreatic adenocarcinoma. That's why we've been defining it for years. It's a way to agree upon the people who does research in pancreatic familial pancreatic cancer. And so of those, about 5 to 10% of patients with pancreatic cancer seem to fit that criteria. And the risk is, as we said, higher and increasing according to the number of individuals affected in the family, as we saw before. So far, we really don't have a single genetic defect associated with familial pancreatic cancer outside the known hereditary multi-cancer syndromes. And these are the ones that we know much more right now. So They are, so here pancreatic cancer would be part of a much bigger spectrum of different types of cancers and of these different syndromes. So they would be part of one of those. And the ones we've known more about is hereditary breast and ovarian cancer with BRCA1 and 2 genes. Lately, we've learned that PALB2 would be in that group too. That's part of the same pathway anyways. Individuals with mutations in STK11, which causes Peutz-Jeghers syndrome. Individuals with CDKN2A mutations, which are the cause of familial atypical multiple mole melanoma syndrome. Lynch syndrome also, mismatch repair genes, and the ATM gene that causes ataxia and telangiectasia. And also, particularly PRSS1, which is one of the main genetic defects associated with hereditary pancreatitis. Those we do understand better the risk of pancreatic cancer within that context. But what is actually the impact of those mutations, of the ones that we mentioned? What's the impact of those mutations in in families with pancreatic cancer? So this is one of the issues that the group here from Zen and et al. Tried to address using basically PAC-Gene Consortium study data. So they took 727 unrelated probands with family history of pancreatic cancer. The majority, 72%, did fulfill the criteria of familial pancreatic cancer. And they looked initially at the rate of mutations in only BRCA1 and 2, PALB2, and CDKN2A. And you can see here in the group with familial pancreatic cancer versus the other group, the control group with no familial pancreatic cancer. And as you can see, about 8% of individuals in the familial group did have one of those mutations that we described here versus a 3.5% for the non-familial cases. And the probability of testing positive was up to about 10% in the cases that there were more affected family members. The study was taken a little bit farther, and this was just published this last month, where they took basically a subgroup of this PAC-Gene Consortium study, 300 individuals from the Mayo cohort. The great majority were already part of that previous study. And what they did is they basically extended the number of genes that they looked at, and not only limited to BRCA genes and CDKN2, but also included the rest of the genes that have been associated with pancreatic cancer within the context of those familial syndromes, and also some other genetic defects that are now being more incorporated in the genetic panels that have been associated with other types of cancers. And they looked at their incidence, again, in familial cases versus non-familial cases. And in this group here is the genetic defects that have been already well established associated with pancreatic cancer, and these are the other genetic defects that there's no clear association yet. So what we can see here is that for the familial group, about 12% of individuals in that with that particular clinical phenotype of familial pancreatic cancer do have these types of mutations versus 4.3% in the group of individuals with non-familial pancreatic cancer. Interestingly, the number of mutations that are not typically related with pancreatic cancer is higher in the group of non-familial cases, and that is certainly interesting piece of information. So another approach is, or another interesting piece of information is, what does it mean having that genetic mutation in terms of risk of pancreatic adenocarcinoma? And here there are important differences that really are worth paying attention to. Really, the most important ones, the ones with the highest relative risk, would be the ones here with the familial atypical mole and melanoma syndrome with a relative risk of 52 and 53 for the hereditary pancreatic cancer genes. And here I think we're more specifically talking about PRSS1 gene. Then we have still pretty high risk, SIR of 13 for the patients who have STK11 mutations, so individuals with Peutz-Jeghers syndrome. In Lynch syndrome, the amount of data is so broad that it's really hard to make to come up with a conclusion. There's data that goes from no effect to an SIR of 8. So I think the consensus is that are somewhere in the middle, but the data is really widespread. And with SIRs of 2.5, 2.1, the BRCA genes, BRCA1 and BRCA2. Looking at this in a different way, so having a PRSS1 gene mutation for hereditary pancreatitis would give us a lifetime risk of pancreatic cancer of 25 to 40. Having the P16 CDKN2A mutation 10 to 17% lifetime risk of colorectal cancer. Peutz-Jeghers STK11 11 to 36%, always hard to pinpoint because of the relatively low incidence of STK11 mutations. For BRCA mutation carriers, 3.6 to 5% lifetime risk of pancreatic cancer, about 4% for Lynch syndrome. So looking at all these, we can conclude certainly in up to 88% of familial pancreatic cancer, the potential inherited genetic defects are still unaccounted for. We saw that we're up to 12%, maybe a little bit more if we study more genes will give us an answer. But really, that great majority is still missing, and really we don't have a good handle on that. Some have suggested that changing the criteria for familial pancreatic cancer, now defining it as families with 2 or more first-degree relatives who do not meet the criteria for known pancreatic cancer-associated genetic predisposition syndrome. So taking away that 12%, all the ones that are associated with the cancer syndromes that we talk about, and really leaving that term of familial pancreatic cancer with the ones where there's this clustering of mostly pancreatic cancers, and not so much on other types of cancers. But again, the actual contribution of inherited genetic defects in pancreatic adenocarcinoma is still overall quite unknown. So who are the individuals who we think that we know they have a higher risk and we should be aware of? Certainly individuals with a known genetic syndrome associated with pancreatic cancer. We mentioned BRCA1 and 2, the breast and ovarian hereditary cancer syndrome, the familial atypical multiple myeloma mole syndrome, Peutz-Jeghers, Lynch syndrome, or other gene mutations associated with an increased risk of pancreatic carcinoma. Then individuals with 2 relatives with pancreatic adenocarcinoma, or there is one which is a first-degree relative of the other one. Individuals with 3 or more relatives with pancreatic cancer, and individuals with a history of hereditary pancreatitis that we've seen really represents an extremely high risk. There have been not that many recommendations in terms of who we need to test for germline genetic defects in individuals with pancreatic cancer. These are some guidelines issued by the American College of Gastroenterology, as good as the others can be. They suggest that at least patients with clinical criteria of familial pancreatic cancer should have genetic testing for the BRCA family of genes, ATM and CDKN2, and they said we can add these other ones. Certainly, that's from 2015. That's kind of old at a time where we have the availability of multi-gene panels. Most of the commercial laboratories are already offering these panels that are geared at pancreatic cancer that will really include all these genetic defects, and it's really almost deceiving, suggesting right now that we are going to be focused on the low-hanging fruit when we already know about these other associations. So I think this is already getting a little bit old, and most of us in practice are really using these panels, particularly in these cases where we don't have a clear hint of if there's any other type or any clear syndrome that can be going on in these cases. So when it comes to surveillance, I'm not really going to touch much on this for these particular individuals, because really this is what really is important here at the end of the slide, which is very low quality of evidence, and that is something that I'm hoping James will address a little bit more. In this clinical guidelines, what they suggest is testing or screening known mutation carriers from Peutz-Jeghers and FAM families because of the very high risk of these mutation carriers. Members of familial pancreatic cancer kindreds with the pancreatic cancer affected first-degree relatives, so the kindreds of the first-degree relatives, those would be the ones indicated for surveillance. And then mutation carriers of families with hereditary breast and ovarian, Lynch syndrome, who would also have first or second degree relatives with pancreatic cancer. So these families with these syndromes who happen to have also at least one family member with pancreatic cancer, those seem to be the ones that would provide a higher risk. But again, we are still here in the field of the very low quality of evidence. So again, in summary, we still have a lot to learn and a lot to be said. When at this time it's become so difficult to find some genetic defects that can explain a lot of cases, I think we all suspect that we're not going to find a genetic defect that's going to explain many of the cases. What we may find actually is probably a good number of different genes that can associate with some of them, maybe some with a very limited penetrance. But at the end of the day, probably it's going to be much more complicated than some of those genetic diseases that we talked about, where the known defects or known genetic defects seem to be the cause of the majority of cases. So stay tuned. There's going to be more information coming up. But this is kind of where we are right now. Thank you.